loved your podcast. I'm Dr. Supriya Mannepalli, Medical Director for Infection Prevention and Control at Northeast Georgia Health System. And I'm here with Sandy Bozarth, Administrative Director for Infection Prevention and Control at Northeast Georgia Health System. Hi, Sandy.
Hello.
Thank you for joining me. We felt that there's so much of important information in infection prevention and control that we would like to share with everyone. So we are starting this podcast series, and this is the first of them. Sandy, how long have you been in infection prevention and control?
I've been working in infection prevention and control a little over 20 years.
Wow, you've seen a lot of changes.
A lot of
Yes,
changes.
I think the most recent one last few years was COVID.
Absolutely.
Yes. So explain to those who may not know really, what do we do in infection prevention and control day to day?
Okay, I think that a lot of people just really aren't sure what we do down in our department. And just as the name says, we prevent and control infections. And probably the most important piece of that puzzle is to identify these infections. And what we call that surveillance. And we do surveillance on surgeries, on invasive devices, on organism acquisitions, things like that. And what we're going to talk about today is an invasive device, urinary catheters, and catheter-associated urinary tract infections.
And I think hospital-acquired infections are one of those important areas of focus for us because they result in such mortality, morbidity, and increased hospital stay and can result in poor outcomes. So as you mentioned, our focus recently in the last few years has been really on preventing and reducing catheter-associated UTIs. Can you tell us a bit where these definitions for catheter-associated UTI come from and how does infection control identify these infections?
Yes, and that's a huge part. We follow CDC's National Healthcare Safety Network, NHSN's criteria. It's very important that all hospitals across the nation are using the exact same criteria so that it's fair across the board. The subjectivity is taken out of it when you have to follow detailed criteria.
Okay. What are the criteria per CDC and NHSN to identify a CAUTI or to call it a CAUTI?
A CAUTI. So the part of the CAUTI, that C is catheter, which we mentioned is the indwelling catheter. And the first component is the patient has the Foley in place. And they need to have the Foley in place for 2 days, knowing that the day one is a day of insertion. And even if that catheter is placed at 11:45 p.m., that is counted as a day, even though it was only in for 15 minutes of that day. There you've already checked off day one.
So it's really the calendar day of the inpatient's day.
Absolutely. Okay. So this catheter needs to be in place for more than 2 days. And of course, the insertion is day one. And the Foley has to be in place on the date of event. We'll talk about what the date of event is soon. And then the second component is the patient has a symptom. And that symptom can be a temp, it can be suprapubic tenderness. There's also some symptoms if the Foley had been removed. There's, it increases the symptoms that are available to use to meet criteria. And then the third component then is that positive urine culture. It has to be 100,000 colonies of no more than 2 bacteria type.
When you mention indwelling urinary catheters, are you referring to just Foleys, or does this apply to suprapubic catheters?
Just Foleys. It's just a
Foley
catheter that goes up the urethra are the only ones that are eligible to meet this criteria.
Doesn't apply to nephrostomy tubes or any others?
It does not.
Sandy, one of the things you mentioned about defining the CAUTI is a date of the event. So can you tell us more about what that event is?
The date of event is the date that the first element used to meet that criteria occurred. And then in a 7-day infection window. So it's easier to see this on paper, but once we have a positive culture, we've look 3 days before that and 3 days after. So that's our 7-day window. And then wherever the symptom falls, because remember we need the symptom to go along with that positive culture. If it falls before that culture, that's the date of the event. If the symptom comes after the culture, the date the culture was positive is the date of the event. So that's very important to us in that 7-day window.
In the 7-day window. It could be a fever, it could be some discomfort, suprapubic tenderness, any of that. Or if the catheter is already out, they may still use dysuria.
Absolutely.
No, thank you. So when it comes to CAUTI reduction, one of the big areas of focus for us lately has been really reducing inappropriate urine cultures. And when we identify a CAUTI, we go back and review. Of course, we look at if the catheter is necessary, and that's also an area we're focusing on, because if there is no catheter, there's no CAUTI. But also, if we reduce inappropriate urine cultures, we can also prevent not only calling it a CAUTI, but also reduce inappropriate antibiotic use and C. diff that leads to increased C. diff, MDRO, all of that.
Exactly.
So, getting into that, some of the clinical scenarios maybe that recently or we have seen where we identified CAUTI because patient met the CDC criteria. Maybe let's go look at some of them.
Let's dig those apart.
Yeah.
Okay.
I think the one recently that came to our attention was someone who got a urine culture prior to a procedure that was not urological. At that time, patient didn't have any symptoms. Patient was screened before a open heart surgery. But after patient had surgery, patient spiked some fever, which can happen post-op within that 24-hour window. And patient met that criteria because that was within that window for the temp and had a urine culture.
Correct.
They didn't even treat that patient as a UTI.
Right, because the patient was asymptomatic.
Yeah. Do we still have to call it a CAUTI even if we don't treat?
Yes, unfortunately we do. If it meets the criteria, whether we treat it or not, or even if sometimes we find another cause later, for that temp, much like this with the post-op temp, it still is a reportable infection.
What if the provider documents in their note the fever is post-op? Does that change
It
anything?
does not. It does not.
When it comes to symptoms, does it have to be in the provider's note, or is it enough if they're in nursing or provider's note?
The nurse's notes too.
Even if it's
way,
not
anywhere we find it.
Yes. Even if it's not mentioned in the provider's note, but if it's in the nursing notes,
correct.
You can still use that.
Even if it's mentioned one time. Yeah, and back to the fever, I mentioned 38 degrees is our point of infection. Even if we have a spike to 38.2 one time, it met criteria.
So there's just been a lot of focus on reducing inappropriate urine cultures, or what we call now as urine culture diagnostic stewardship, because catheter being a foreign body, bugs can stick to that and call what we call as a biofilm. Again, for oversimplifying it, but it's like a colony of bacteria that stick together and can just stick to that catheter. So when we are getting a specimen from that catheter, what we are culturing is that biofilm.
We're drawing that urine through that biofilm and gathering all the germs that it
may
collects.
not indicate infection, right? So actually recently there have been a lot of evidence, studies published where they show that even increased WBC in the urine in a patient who has a urinary indwelling catheter, increased WBC more than 10, or what we call as pyuria, doesn't necessarily mean infection.
Correct.
It could just be from the local inflammation from the presence of the Foley.
From the catheter.
Any other scenarios recently where we called it a CAUTI when could not?
Pan cultures. I think that most hospitals have this problem where a patient might spike a temp and they do the pan cultures. And those pan cultures might show a positive urine because the Foley's been in place for several days, but then it might also show that we have something growing in our sputum. So even if the doctor says, I realize now this is pneumonia and the patient's asymptomatic as far as urinary tract goes, I'm not going to treat that. It still met our criteria.
I think that's a great point. So if we do pan cultures, because I think we have that knee-jerk reflex when someone has a fever or change in clinical status, we order multiple tests. We order some imaging, cultures, as you mentioned, pan cultures, blood, sputum, urine. And even if we identify that the change in the clinical status is from pneumonia, we still have to call it a CAUTI if the urine is positive and met other criteria. And something else also we've seen recently was where patient gets urine culture prior to Foley placement or on admission when they're putting the Foley.
Does that save us? Is that what you were going to ask?
Yes,
and
I get that question often.
Yeah, like present on admission type thing. And it would if they met all the criteria. So just that positive culture. Remember I had said there was this three components. unless they have the symptom with that positive culture, and we can say they have an active urinary tract infection, we can't consider it present prior to the insertion of that catheter.
And it's really not a recommended best practice.
No, because so many times you'll get a positive culture, and then what do you do with it? I think you're tempted to treat it, which leads to unnecessary antibiotics, and we know where that goes as well.
So it's really not recommended to get a catheter at the time of, or get a culture at the time of catheter placement or on admission.
Correct.
Yeah. Okay, great. Some other clinical scenarios we've seen is where patient has some discomfort and there is starting of dysuria after the Foley comes out, like a day or so later. And then, but patient has no fever, no suprapubic pain, no flank pain, otherwise stable, and a urine culture is obtained.
And while dysuria can be, a sign of a UTI, it can also be a sign of inflammation. That catheter's been in place, and so if possible, to push fluids and for a day or so to see if that inflammation will go away, I think is best practice. But
and I think speaking with our urology colleagues and experts here, they also actually recommend that. It's kind of expected that there may be some discomfort because they've had the catheter from that local inflammation.
Absolutely.
So if the patient doesn't have any other symptoms, is otherwise stable, to just monitor and not get the urine culture, continue to reassess them. Something else also we've seen where fever is a cause, even if there's no change in clinical status, but there is temp, just fever, that leads to pan cultures.
It does, yeah.
And that's also
it's a knee-jerk reaction for sure.
Knee-jerk
reaction. To test everything to find out as quick as possible.
And we have seen where sometimes the fever is from a hemorrhage somewhere or a DVT, or we've even had some cases of COVID detected or flu. But then the pan cultures, urine is positive, patient has had a Foley.
Absolutely.
And we had to call that a CARTI, even if we identified some other cause of the fever.
Yeah, absolutely.
And that does not really change what infection control does in terms of surveillance or reporting, right?
That is absolutely true.
Okay. There was one more scenario where we had someone who had C. diff and was having increasing abdominal pain and fevers and had to be moved to the ICU, and got pan cultures as part of that workup for worsening sepsis, which ended up being a result of worsening C. diff infection, but then ended up having a positive urine culture.
And in that case, that's even more reason why you don't want to give that antibiotic unnecessarily for the risk of C. diff.
Absolutely right. I think one of the things we've been trying to do is use an algorithm to guide providers to look for other causes before we get urine from a patient with a Foley catheter. There are some studies that said that within few hours that biofilm starts forming, and if there's more likelihood that we'll have a positive urine culture or pyuria than not if we're obtaining urine from that patient who has had a Foley catheter. If we do need, let's say we have done all the workup, we don't find any other cause, and now, or if a patient has clear signs and symptoms of UTI, and we have to collect urine from the Foley, what is the recommendation?
Well, because of the biofilm that you just spoke of, if that Foley's been in place for 3 days, we would like to swap it out. We'd like to take it out. So I should clarify. We'd like to take it out and leave it out. But if that's not possible, replace it with a clean one so that we're not pulling that urine through that catheter and across that biofilm.
No, thank you. I think that's very, very important that at least we make an attempt. And if there was just a mild infection or local inflammation causing these symptoms, just swapping out that catheter may take care of it.
Absolutely.
And if the patient is stable, maybe we can even reassess in 24 hours and see. But if the patient is not stable, getting septic, at least change the catheter out, do the workup for other causes. And if all of that is negative, like blood cultures, then if you need to really get the urine, at that time, get it from a new catheter. I've seen some algorithms from other health systems where they recommend, of course, cultures from blood, if imaging, X-ray of the lungs, if need, look for DVTs, especially now we're in the COVID flu season, look for any viral infections causing the fever or the clinical presentation, and urine really being the last, unless there are clear signs and symptoms of UTI.
And I think another thing we don't talk about enough is obtaining the specimen correctly. Obviously not from that bag.
Very important.
So either use the kit,
Mm-hmm.
Clean the port well before you get that specimen, and then get the specimen to the lab within an hour would be ideal, because the longer that sits at room temperature, and it multiplies and multiplies, and you go from a 50,000 colony to 100,000, and we know what 100,000 colony does to our COTI criteria.
Right.
Yeah.
That's very, very true. Hopefully, all the focus we have had on urine culture diagnostic stewardship, we're working with collaboration with medical staff, lab, nursing. Of course, our infection control has been also very much involved with our COTI reduction team. Hopefully, we'll see a change in reducing this inappropriate urine cultures, because it is evidence-based.
Absolutely.
And it also not only helps reduce COTI rates, because we won't be calling them as COTIs when they're not true infections, but also reduces antibiotic use. There's a lot of temptation to give antibiotics.
Yeah, when you see that positive
when it's
culture.
a positive culture and pyuria, all of that, and helps with reducing C. diff rates, MDRO development, all of that. There's just so much more to talk about COTIs. So we may have to bring in some other experts next time and talk about maybe the indications for the Foley catheters. How can we avoid placing them in the first place? And I think the big things, or the two common causes we see, are retention and strict INO. So hopefully we can bring in more experts to help us understand that more. Thank you again for tuning into this podcast, and we hope to see you again soon in the second part of this series of Infection Prevention Control podcast. We'll continue discussion on catheter-associated UTI prevention, and hope to bring in some other experts who can help us more to understand the need for the Foley, how can we avoid them, and also address the two most common causes for Foley use we see here, which is urinary retention and strict inner INOs. Yeah. Thank you again.
Thank you.
Thank you, Sandy.
You're welcome.